1.
Hello, everybody. This is Paolo A. I'm a medical oncologist, and I work in the Department of Melanoma, Cancer Immunotherapy, and Development Therapeutics at National Cancer Institute of Naples, Italy. First of all, I'd like to thank NanoString and organizing for the kind invitation. It's a really pleasure for me to be here today to discuss about how COVID-19 has changed an immuno-oncologist's life, from optimizing our daily practice to the targeted treatment of the cytokine storm. Here are my disclosure. In the era of COVID-19, the first rule is to keep everybody safe. What does it mean to keep everybody safe? It means to keep safe patients and healthy workers, physicians, nurses. But what we can do in order to minimize any potential patient's exposure, because, you know, to keep patients safe means to avoid the possibility to spread the infection. One of the first things is to avoid gatherings, because with gatherings there is a high risk of infection. And of course, it's important also a triage in order to recognize people with fever who can get symptoms of COVID-19. And of course, it's fundamental to use the DPI. But it's also important to prioritize patients, and I will show you what does it mean, prioritize patients in our daily practice. And of course, the test, this is more something important during the phase 2 after the first wave of the infection. What I'm going to do in the next minutes is to discuss with you what we did at the National Cancer Institute of Naples, so mainly at my department of skin cancer and cancer immunotherapy. So I just told you that to prioritize patients was one of the most important rules, but what does it mean? This means that we have cancer patients to different stages. And of course, there is a priority and a different priority between the patients with low risk cancer, in this case, melanoma, or patients with high risk. So if we look to the patients who need of surgery, we gave priority to the patients with P53 and primary lesion T4 compared to the patients with T1 and T2 with a lower risk. And of course, high priority was given to the patients where surgery had any curative important meaningful. So for those patients with the stage 3 melanoma or who needed of resection for oligometastatic disease, these kind of patients had the priority compared to all the others. Also for the follow-up, the rule of to avoid gathering was important because, you know, in the waiting room, the gathering may be one of the potential risk for the diffusing the infection. And for this reason, we used the telemedicine. We reached by phone all the patients in follow-up, and mainly the patients, of course, with low-risk melanoma. And in case of no evidence of disease, of course, we asked to the patients to postpone the next visit. But in case of evidence of disease, the patients was, of course, admitted immediately to our department in order to check, visiting the patients, what happened. Looking to the adjuvant setting, you know that now in the field of melanoma, there are some important treatment, and we used all the 12 weeks that in general we need for starting the adjuvant treatment in order to optimize the access to the hospital, because, you know, we have the seats where the patients are treated, and still in order to avoid the gathering. For the patients with BRAF mutated, sometimes in order still to avoid the gathering, we preferred the BRAF and MEK inhibitor because these are tablets, and if we have a lot of patients who need infusion, of course, this was one of the possibilities to reduce the number of patients in the hospital seats. And for the same reason, we preferred also the longer schedule, so pembrolizumab and nivolumab every 6 or 4 weeks, still in order to avoid the seats full of patients and to avoid the possibility to spread the infection. But of course, the highest priority was for the metastatic patients. For these patients, no stop or delays for both immunotherapy and target therapy. And the only things that we did is just to prefer the longer schedule. Special issue for clinical trial, because, clinical trial should be conducted according to the good clinical practice. And, in this moment, with the lockdown, with the possibility for patients to not be able to reach the hospital, of course, some clinical trial and mainly phase 1 trial are on hold. And for the patients who were already enrolled, we are using still the telemedicine for the control visit. And in general, in agreement also with the regulatory agencies, what we did is to assure the safety for the patients who were participating to the trial, to maintain the compliance with the good clinical practice, and of course to minimizing the risk for the trial integrity and the quality of data. Special warning was for some side effect. You know that the pneumonitis are an important side effect from checkpoint inhibitors, mainly the anti-PD-1. And you know that one of the most important complications of the COVID-19 is the pneumonitis with the respiratory distress. For this reason, in the patients with sign of pneumonitis and with fever, so what we did is to test the patients in order to be sure, with a nasal swab, in order to be sure that there was no infection by COVID-19. You know also that BRAF and MEK inhibitor can give fever, and in general, this fever disappears with the stop of the treatment. In case that the fever does not resolve with the treatment interruption, still we did and we are doing a nasal swab in order to be sure that there is no COVID-19 infection. You know also that as immuno-oncologists, one of our main concern during this period for our patients treated with checkpoint inhibitors was the possibility of an increasing of risk of pneumonia for these patients. But this risk is only hypothetical because at the moment we don't have any data available. We also heard from the virtual meeting at ACR experience from China, from still Italy, in the patients with lung cancer treated with checkpoint inhibitors, from France, from New York City, that there was no increase of deaths of side effect in the patients treated with immunotherapy. There is also another important consideration, because there are some preclinical data that suggest that anti-PD-1 could increase the virus clearance. These are data that came more from the flu, but this is also something that we should consider. In fact, anti-PD-1, in general, checkpoint inhibitors, could be also protective. I'd like just to report to you the experience of my institution. At the moment, we have on treatment with checkpoint inhibitor something like 400 patients. And in our institute, in my department, we got only 2 patients COVID-19 positive at the nasal swab, but these patients were both in treatment with Adjuvant, were asymptomatic, and they recovered earlier with a negative test in less than 10 days. So this is something that we should, again, take into account. It's interesting at the moment, a clinical trial, a French clinical trial, the Immuno-oncologist, that is exploring also the possibility of anti-PD-1 to be predictive. It's an interesting randomized phase 2 trial with 2 cohorts. Cohort 1 with patients with mild symptoms or asymptomatic, and cohort 2 with the patients with moderate severe symptoms. And the difference in these two cohorts, where there is a randomization 1:1:1, is that while in the first cohort, the better patients, there is nivolumab, anti-PD-1, in the second cohort, the tocilizumab. The GNS561 is a chloroquine-derived compound. But it will be interesting to see the data from this trial. But what can also we do as immuno-oncologists during this period of the COVID-19? You know, this is the time course of the virus infection with coronavirus. Immuno-oncologists could be useful during this part of the host inflammatory response phase. And why this? Because we know very well that with the checkpoint inhibitors, we can get some adverse event, some immuno-related adverse event. And as I already discussed, pneumonitis are some adverse event that could be something similar to that happened with the COVID-19. And in fact, as you can see, for these kind of immuno-related adverse event, what we do in general is to use high-dose steroid, but in some cases of steroid refractory pneumonitis, we use other drugs like anti-TNF-alpha or anti-IL-6 like tocilizumab. We know also in the field of immunotherapy, and mainly in the field of hematology, that the treatment with the CAR T-cell is able to give another typical adverse event, the cytokine release syndrome. And we know that in this case, there are some important cytokines like IL-6 that are the cause of some adverse event like hypovolemic shock or pneumonitis. And we also knew that the ARDS by COVID-19 is due to a condition similar to the cytokine release syndrome. So it's due to a cytokine storm where IL-6 is important in generating the respiratory distress that is sometimes the cause of the death of the patients affected by COVID-19. For this reason, to target the hyperinflammation, to target the cytokine storm, may be an important strategy in order to cure, to treat the ARDS by COVID-19. And for sure, the possibility to use anti-IL-6, it may be something of crucial. Indeed, IL-6 may have several important roles in the inflammation, immunity, and as you can see, IL-6 has several important actions on the several immunosystem cell, but not only, even in the hepatocyte, increasing the C-reactive protein, and other actions that are listed in this slide. For this reason, to use anti-IL-6, and here I listed some of the most important, maybe, as I already said, an important strategy. When we discuss with some Chinese colleagues about this possible idea, they told us that this was an interesting idea. They already treated 21 patients in a pilot experience, and interestingly, 20 out of these 21 patients recovered from the COVID-19 pneumonia in 24-48 hours. So this was really an amazing result. For this reason, on 7 March, we treated the first patients. Here you can see a male born in 1972 with a concomitant history of a cardiac disease, hypertrophic heart disease. And as you can see, the patient was treated with tocilizumab after 3 days from the admission to the intensive care unit, and he got an important response in a few days. Here are additional cases, a young male born in 1993 with no comorbidity. And this is important because we have seen in intensive care unit not only elderly patients, but also sometimes young patients. Again, the tocilizumab gave an important recovery to these patients, as you can see here in this slide. After these important results, we designed a clinical trial, the TOCIVID-19, at the moment still ongoing. We enrolled the patients with COVID-19 pneumonia, with oxygen saturation at rest in ambient air of less or equal to 93%, intubated less than 24 hours before registration. And as you can see, the primary endpoint was the lethality rate at 1 and 2 weeks after registration. We enrolled 330 patients starting from 19th of March, and we enrolled all these patients in 24 hours. This just to give you an idea about how important was the problem in Italy at that time. And we used the dosage of tocilizumab of 8 milligrams per kilograms. That is the classical dosage that we use in the CRS of CAR T-cell therapy, with a maximum of 800 milligrams per dose of tocilizumab, with possibility to repeat the dosage after 12 hours. At the moment, we are waiting for the results. The data cutoff was on 24th of April. We are just collecting now all the CRF, and the data should be disclosed, probably will be disclosed very soon in the next days. There was a parallel study, an observational cohort. Here you can see the patients enrolled on the 31st of March, but at the moment are more patients, close to 3,000 patients. The difference between this observational cohort to the phase 2 and here, as you can see, the only criteria that was different is that even patients intubated more than 24 hours were treated. This cohort will be also important because we will get data from a sort of real-world evidence in this group of patients. And still, look to the Italy map. The tocilizumab was used, largely used around the country. This is another interesting case, as you can see here, of a patient still was treated with tocilizumab and who got a response. The interesting part is that the IgG and IgM against the coronavirus appear just 24 hours from the tocilizumab infusion. So this is interesting. Another interesting point will be in the follow-up of these patients, because here, again, this is one of the patients who was treated at the beginning of this story. And after 1 month, he developed an important fibrosis. We will see now with the follow-up if this fibrosis will affect the quality of life. So this is another important issue that we will see now in the next future. You know that at the beginning, before the clinical trial, we used the tocilizumab as per off-label. This was the possibility to get the drug, but sometimes the drug was not available because there was an important number of vials requested, that sometimes there was a delay of 6-7 days. And you know that the time was very critical for these patients. Sometimes some colleagues in some intensive care unit used the sub-Q of tocilizumab, and they got interesting and still important response. For this reason, we also used another anti-IL-6, the sarilumab, at dosage of 400 milligrams sub-Q, 2 vials of 200 milligrams as a single administration with possibility to use again after 12 hours another administration in a series of 15 patients. Here you can see the baseline patient's characteristic, and also, as you can see, several patients were overweight and obese. This is important because you know that in this kind of patients, there is an increase of production of IL-6. 8 patients were intubated, while 7 are not intubated. Look to the characteristic of the patients who responded to sarilumab. Look to the number of patients intubated and not intubated. All the not intubated patients responded, and they got an important recovery in 76 hours, and even 3 out of the 8 patients intubated also recovered. Look also to the median PF ratio that was close to 300, not so bad. And all these 15 patients had high baseline level of IL-6. This was a condition that we consider in order to treat these patients. In this group was 56.6. Remember this data, then we will compare with the non-responder patients. The baseline absolute lymphocyte count less than 800 that you know was considered an important cutoff as a negative prognostic factor. High level also dimer. Platelets normal, and also the C-reactive protein was high, and you know this is strictly related to the IL-6 level. And also look to the median of the neutrophil lymphocyte ratio that was 9.5 in this group. Here I'd like to show you some of these cases treated with sarilumab and who get an important response, a recovery of the respiratory parameter in 72 hours. This is one of the cases born in 1906. Here an additional case of a patient born in 1957. Additional 2 cases. Again, patients who normalize in 24 hours. And here another page, date of birth 1964, like my year, with another important recovery in 48 hours. Look to the patient's non-responder characteristic. 5 patients, all these 5 patients died, all the 5 patients were intubated. And look to the hematological values. The median baseline IL-6 was 56.6 in the responder. Here higher, 213. Also the baseline absolute lymphocyte count, 500, lower than 800. Higher value of dimer, C-reactive protein higher than the responder, and also look to the median neutrophil lymphocyte ratio, 19.5 compared to 9.5 of the responder. So in these patients, probably the cytokine storm was really higher, and the treatment was not able to recover this situation. Probably more interesting are the data from the biomarkers evaluation. In blue, you will see the data from the responder patients, in red from the non-respondent. Look at first to the CRP. The CRP seems to be the best marker in order to follow the patients, the best prognostic marker, because while there is a decrease in 3-5 days in the responder, in non-responder is no decrease. IL-6 is not so good for the follow-up because, you know, anti-IL-6 are able to make free all the IL-6 that is bound to the receptor. For this reason, you see an increase after the treatment. Even the platelet went down in non-responder, and look to the difference of the neutrophil lymphocyte ratio between the non-responder and responder. There is a very important separation. The curves, the trend of the curves is totally different. Again, absolute lymphocyte count is stable with an increase in the responder. There is a decrease in non-responder. And finally, the eosinophils that increase in the responder, decrease in the non-responder. Of course, we need data from clinical trial. There are at the moment 2 trials, one with tocilizumab is a phase 3, another with sarilumab is a phase 2, phase 3. From this last, there was a press release a few weeks ago that anticipated that the sarilumab at dosage of 400 milligrams seems to be more effective in the critical patients, that are the patients that even we consider for the enrollment in COVID-19. So in conclusion, we believe that to target the cytokine storm may be important. And targeting the cytokine storm means not only to target the anti-IL-6, because there are several cytokines that are involved in this condition. For instance, the JAK inhibitors are important. There are several compounds. Even the anti-IL-1 inhibitors, like this, anti-TNF alpha mainly, several compounds. Another interesting category of compounds are the anti-IL-17 and anti-IL-23. Here a very important list of compounds. And also GM-CSF, again, an important number of drugs. So in conclusion, just to summarize what we have seen and what I said, so during this era, we should be cautious with no panic. Of course, the first rule is to keep everybody safe, patients and physicians and nurses. And to target the cytokine storm seems to be really important and crucial in the treatment of the ARDS by COVID-19. Having said that, I'd like to thank you for your attention.